First of all, thank you everybody very much for coming. We have wonderful representation here from CVICU, from pulmonary, from transplant, medical, surgical side, from different scientific groups. So this is fantastic. This donation cuts across all these areas, and Dr. Snell is going to be talking about that and kind of the Melbourne approach to things, which has been very innovative and informative in the world. I'll start with a land acknowledgement that we acknowledge that the U of A is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Nations people of Canada. And also, the perennial thank you to Paladin for the support of this series. It's an important series, and especially when we can get in-person sessions like this to get everybody together. I'll just start by introducing Dr. Snell. Professor Greg Snell has an established international reputation due to significant expertise in advanced lung disease and human lung transplantation. He's the medical head of the lung transplant service at the Alfred Hospital, which is one of the largest and most prolific lung transplant programs in the world. So typically doing sort of on the average of 100 per year. I think COVID affected those numbers a little bit, but a very big center in the world, and also a very big academic center in the world. Dr. Snell had his MD awarded in 2007, which it was eye-popping to me because it's the same year I received my MD, but it works very differently in Australia. There are physicians long before they get their MDs. And that was through Monash University, which is affiliated with the Alfred. And that was for research undertaken into lung transplant donor and recipient selection. So he's a long-standing interest and commitment to end-stage lung disease and lung transplantation, clinical and airway immunohistopathological research. And the big areas of research have been DCD, donation after cardiac death, organ retrieval, which the Alfred really has, and Dr. Snell in particular, has really pioneered major innovation, major contributions to what we know about DCD, which is now a big source of lung donors for us at our center. As well as unrelated to lung transplant, bronchoscopic lung volume reduction surgery for emphysema, and he performed the world's first case and described that initially, and finally into chronic rejection in the lung transplant. So he's a total of 400 publications across the spectrum of advanced lung disease and transplantation. And in 2001, he was the first investigator in the world to describe bronchoscopic LVR, where lung volumes can be reduced without the need of a thoracic surgery in humans, and has published widely in this area. And he is the only individual to have been a participant in the ISHLT, which is our international organization in lung transplantation, covering acute rejection, chronic rejection, primary graft dysfunction, donor and recipient selection. And he is I will say he's a major contributor at the ISHLT and a major force there internationally. And he also wrote the Australian guidelines for lung allocation and recipient and donor eligibility. And I'll just add on a personal note, I met Dr. Snell, I think 13 years ago at the ISHLT when he came and sort of just engaged me about a poster that I was presenting there. And that's just how he's always been since. He's just always available for interesting academic and clinical conversations, and he's the consummate academic clinician, and a big thanks to all your support over the years. So please join me in welcoming him for Donor Lungs for Transplantation Strategies and Lessons Learned.
Thank you very much, Kieran, for that introduction, and thank you for the hospitality that's been extended over the last 10 days. My idea was to sort of sneak in and just have a look around and look over people's shoulders, and it's ended up as being quite a tour de force of getting around and talking to people and seeing things. And every time you go somewhere and look at another program, you get ideas to take home. But this is some of what we're doing. So there's many myths in lung transplant, but the first is that the lungs are sort of an equally damaged sponge, and the ICU would say, oh, there's no point in referring them. They'd never work. They're too damaged by the processes of death, the resuscitation, the smoking. It's all too hard. There's not many lungs are usable percentage-wise, and not many lung transplants are really needed or done. It's a small sort of thing, and they die early, so it's hardly worth it. But these are myths that we can bust, and truthfully, there's a lot more to be done. It turns out that lungs are actually usable in around 50% of all donors that yield any organ, and that lungs actually recover from fluid bruising, consolidation, trauma, etc. And then if the poor guy who's had a car accident and had major head injury had have been 5 centimetres to the left of the pole he hit, then his lung problems would have not impaired him long term, and he would have been perfectly well if he hadn't been an organ donor. So they just might look bad at the moment. Lungs also turn out to be remarkably resistant to ischemia. There's not a syndrome in ICU that you really associate it with ischemic lungs, yet we know that the kidneys, the heart, the brain all show clear-cut syndromes. And the lungs can actually sit there for 2 hours, room temperature, and after an arrest, and basically be quite usable. And you've got time to assess the lungs, and you've got time to resuscitate them, and lung transplants work. So what do we do? Well, this is the Australian version of the world, with us at the top and Edmonton, for those who don't know where it is, down the bottom. You'll notice on this map that Toronto didn't actually get a dot. And I was struck by the fact that Greenland's closer to Canada than it is to the US. So we'll be leading from the top. For the sake of clarity, though, I've turned the world around, and this is Australia overlying on the US. And basically, our backyard is several thousand kilometres across, and we will use organs routinely from all of these places, including New Zealand, which doesn't quite fit on the graphic. And our story essentially is that we've been using more and more organs over time, and the run into COVID was shown here with this graph, where we're working off a 7 million population with around a third DCD organs. And we drive the numbers in Australia as the largest centre there, and compared to the US, they're similar in brain dead, with a much higher per million population down the bottom, but the use of DCD organs has been a lot less. And down the bottom, you really wouldn't want to be a patient in the UK who needed a lung transplant. I'll talk about a series of database reviews that we did. So if you basically take this one here, there's 708 lung referrals from our state, so less than 200-300 miles away, mostly from the big cities, but some from smaller centres, from 17 ICUs in a 4-year period some time back. And you can see there that there was around the same number of brain dead, the DBD and DCD referrals. 54% of those organs that were where any organ was used, we were able to use the lungs for brain dead, and it comes down to 48% was suitable for potential retrieval from DCD. But in our hands, not every DCD progresses to cardiac arrest in the 90-minute or now 120-minute time zone. So there's some redundancy, and I'll talk about that as we go on later, how we might pick up those 37%. So our numbers, as Kieran said, we're running above 100 for a few years there, with stuck in about 75 post-COVID, as the world has changed for us a bit in terms of both staffing and I think the way the system works. There's single lungs in there. Single lungs are a very useful way of doing 2 people at the same time, or one lung that's perfectly good when one lung's terrible in a donor, and doing a single lung, and they work very well for IPF patients who are going to die next week. Our outcomes are solid, with around just coming up to 2,000 transplants done, and pull away from the from the International Society registry at all points. And importantly, we're using the more marginal organs at the time when they're available. We get people transplanted, and I've made the point to a few people, it's all about intention to treat. It's really intention to treat from when you first see them, to get as many people alive for as long as possible. It's not about just doing the clever transplants and seeing what happens to them if you've left a whole lot behind who didn't make it onto your list or didn't make it after the transplant. And ISHLT talks about, I think, a 25% waiting list mortality, and the UK is something like about a 40% mortality. Our referral path for lungs, basically, there's a donor coordinator who speaks to a lung transplant coordinator, and they present bits and pieces to the physician. And the physician will then work on with that, back with the team, back with the coordinator, or possibly even the someone in the local intensive care. And I was saying earlier that almost the smaller the intensive care, sometimes the better reception you get when you have a discussion, because you're talking to someone at 2 a.m. who's keen for information and trying to be very, very helpful about the minor changes you can make. Of course, we've got to be completely respectful of the fact that we're from the transplant team and we're not taking therapy, we're just suggesting. And as I said, single lungs could be useful where no other organs are available, or just double lungs in where the vascular problems have all taken out all the other organs. And we can go round in a loop with gases and x-rays and discussions and bronchoscopy and things, and try and use the time we've got. The other thing we've done is effectively set up an ICU lung transplant hotline and said if anyone wants to ring us at any point and ask questions about what we're interested in, the history of cancers in the past, or the age limit, or anything at all, we may not even be in the rotation of who's getting the organs, but we'll happily take a phone call and have a discussion, just so that people are educated. And finally, we sort of, the surgeon in our model appears at the end there, and we've left them to sleep so that they're less grumpy, and they're actually and they're not sort of held up with a lot of the backwards and forwards on the donors that are rejected. So in terms of where we're up to with our lung acceptability criteria, essentially now we take donors happily up to 75, and I think that will go up higher. In Europe, they're transplanting donors into the 80s. The oldest donor that's been transplanted for lungs is 94. Single lungs, if there's single changes, bilateral, if there's bilateral changes. We repeat the gases, we're happy above 250. And there's bronchs and changes in PEEP and changes in fluid status that are discussed. And basically, if the X-ray sort of looks all right, the oxygen's sort of all right, and the smoking history is reasonable, we're off and running, and that's been for a time. We're not interested particularly in aspiration. It's usually wrong. We're not interested in the gram stain, and secretions don't really worry us, and the X-rays are never normal. And this was a study of a few years back. The chest X-ray, even back then, was abnormal in 67%. Aspiration was present in 41%. The smoking history, 57% of the donors had a smoking history. So you're more likely to get the lungs of a smoker than and sometimes, and the condition you've got is emphysema from your own smoking. Airway secretions almost invariable. So less than 5% of all donors are ideal. Less than 10%, so all donor offers are ideal. Less than 10% of the donors used are ideal. And as I'll be talking about, there's more than 60% of all of the donors would actually meet the criteria that are published for the use of ex-vivo lung perfusion that another centre in Canada has made a big deal about. And we'll talk about. So lungs that work, there's bruised lungs that you can chop off, consolidated lungs, bruising doesn't matter. Collapse and consolidation these days is absolutely normal on the CT scans that come back, and it just, if the surgeon's happy looking at them, as they usually are at that point, they look pretty good. If you actually go and look at them, they're fine. And this has then led to sort of these are 3 cases that are just from this year as we tried to get cases done. So the first one from this year, 25-year-old male donor who clearly aspirated, but the oxygenation was good, and he's 25. His bronchoscopy doesn't look very good, and particularly while you're having lunch. But the guy was, we had a sick recipient, and we went ahead and transplanted him. He was complicated, but he'd been in the hospital for 2 visits to ICU, and was finally in ICU, and wasn't going to go on ECMO again. But he'd been, as I say, months in hospital waiting, pulmonary hypertension with ILD, and the surgeons were nervous on the back of the case, put him on VV ECMO, but this is the X-ray the next day, and came off ECMO the day after. It turned out not to be necessary. And his airways, which were horrible, by day 16, it completely cleared, and he went home about day 20 as if it was all perfect. And again, we're backing there the good gases and the 25-year-old donor, and the fact that we believe that we could brown those lungs with antibiotics. Second case, a female donor, again with aspiration, solid marijuana history, a solid risky social history. Gas is not so good, and CT scan again is not looking ideal down the bottom there. But again, had a sick recipient, this time, day one, his X-ray is, which admittedly I didn't show the other earlier X-ray. You wouldn't have known that there was any particular problem. The payback for us was the infectious diseases that this person had managed to acquire almost one of every bug that you could have, which we're able to defeat and it all sorted out well. And again, at the end of the day, there's a 21-year-old donor that's been used that would have been rejected. And the third sort of case, these are all from January, February, was a 16-year-old male who was basically noted to fall to the ground and hit his head on a rock and had a bleed. He hadn't been behaving normally in the 15 minutes beforehand, and it turned out that they realised that he'd been bitten by a snake and was given anti-venom with good gases. But in fact, it turned out to have the recipient had an allergy to the anti-venom, and again needed some ECMO, which after 3 days cleared and we're off and running. Sure, ECMO fits in here as a bit of a backup, but at the end of the day, these are young donors that people would have easily said perhaps shouldn't have been used, and at the end of the day, you can use them. And that's just sort of, that's over a 2-week period, sort of these are the type of things we're considering. The ones we don't use though, the one on the left was the one that surprised me the most. There's a chest X-ray, and when those lungs came out, they were pictured down the bottom of the green lungs. And this guy would never have gone to the age of 50 or 60 with those lungs. That marijuana was clearly not going to do good things, and perhaps explains sometimes the peripheral changes you see on a heavy marijuana smoker. And another marijuana smoker here, a 38-year-old female whose chest X-ray looked a little bit ordinary, but the CT scan was horrific with these cavities from aspergillus, and again, possibly reflecting the climate and the humidity, and that the marijuana is not dry enough. And a heavy smoker, and that one actually came off the internet, that picture, that wasn't one that we looked at. But you've got to have a lot of cigarettes to cause that much. So if we look at the used donors that we have, the smoking story essentially is there's nearly a half of them, as we said, there's 57%, so 43% of them are in the never corner up there. But if we go down, even if there's current smokers, ex-smokers, and the marijuana ones have 33, they are all significant smokers of cigarettes and that as well. So it's we then went on to just then look and see what happened. And this is just a 3-year survival related to the donor smoking. And the survivals are generally very good, but it is still true that if you have a never smoker, you'll do better than a former smoker, which is better than a current smoker. So smoking is not ideal, but this is at 3 years, and if you're going to die at 14 days of your pulmonary fibrosis, this is still a better outcome. And indeed, the next curve is from a revisit to a series we did back in I think 1996, looking at smoking back then. So there's a older sort of survival curves, but this is never smoking less than 20 pack years or more than 20 pack years. And you can see that it actually, there are people who had 30 and 40 pack year smoking donors who are still here to tell the story at 10 and 15 years on. It's something to not completely discard. And practically, we've ended up with about a cut-off at about 30 pack years, with more anxiety with marijuana on top of that, where we believe both of acute infections and also the I think the marijuana curve long-term won't be as good than tobacco, because each marijuana cigarette's 6 times more likely to give you an OB picture. Donor age is something that's quite clear now. We've just published on our series and done a literature series that donors don't seem to run into any particular troubles in the modern era, and Europe's shown the same, and the US has yet to discover this. And that in fact, the cherry picking, this is not an RCT, cherry picking, the older donors do just as well as any other group, and arguably cherry picking, if they're, again, compared to a 70-year-old who's had a stroke, or a 73-year-old who's had a stroke, who's got nothing wrong with their lungs, never had a cigarette, never done anything wrong, may well do better than some of those 25-year-olds I showed earlier would make sense. And if anything, the worst curves are less than 65, which is perhaps representing that they're less picked through. And just to show the recipients' survival over time, the 70-year-old recipients, are heading towards vaguely reasonable 3,650 days. Sort of at 10 years, it's not going to be a long way off the others as well, and perhaps we're doing better with the learning curve of that. So age is not quite as important as we've said. So EVLP, the elephant in the room, particularly here in Canada. If we look at the reasons we decline lungs, there's reasons around organisation, how the team's set up, general medical issues, including cancers and things, and smoking, abnormal X-rays, lung disease, low PF ratios, aspirations, things about lung quality. The organisational things, there's transplant staffing space. No one on the waiting list of that AB blood group or the cross-match won't let us do anyone. They're too big or they're too small, cancer and the like. So they're things that are hard to fix. So when you talk about, and the other comment there is that it's not, you need to be thinking of the thing in 3D. There's secondary problems. There's lung quality problems, general medical and organisation across the top. But if you go down the first column, you've got the patients who had lung quality problems also had a significant number of them also had general medical problems. Some of them had organisational problems, and some of them had everything. So you're dealing with not just one problem, why those organs weren't used. So 45% had more than 2 reasons. So if we look at these so-called extended criteria donors that people talk about for ex-vivo perfusion, and we went on to look at this and noted that 62%, as I said, of our patients actually had an EVLP criteria. The EVLP studies that have been done have basically picked out the yellow boxes from here, and I've used our lung quality, general medical and organisational issues. And EVLP could possibly fix the gases, improve the X-ray, help with aspiration. It could possibly treat pulmonary embolism or tell you about it. It could possibly improve the lungs after ECMO. It could help you with your logistics. So maybe EVLP could fix these things, but the rest of them it can't. And you knew all the rest of those things before you even started. So EVLP is already limited to what it could look at. So ex-vivo lung perfusion, where the lungs are taken out and put on a machine, perfused and ventilated, and the surgeon fondles them and plays with them for about 4 hours, and then says they're now good to transplant. So if you go back and say, well, we actually had a machine, but the surgeons were finding that it was too long for them to operate. If they were on for the day, they didn't want to do the machine and then have to do the transplant. They'd rather, after a while, they said, can we just do the transplant? So if we looked at the criteria, some of these things have some importance on univariate analysis, but the age of the donors, which in the studies was less than or greater than 55 years, the history of aspiration, the DCD or DBD, the blood transfusions, the PF ratio, none of these things actually made any difference at all. Maybe the X-rays did, an ischemic time might as well, but if you then put them into a multivariate, surprise, surprise, none of those things make a difference. And what makes a difference is a diagnosis of pulmonary hypertension, or CLAD, which is chronic rejection, which we sort of know that the toughest cases, or using bypass, which we also know causes a primary graft dysfunction. So these criteria didn't actually influence at all how the lungs went in the early period postoperatively. In the longer term, they didn't actually make too much difference with the 3 years either. That what made the difference still was whether they had pulmonary hypertension or chronic rejection, because they were the toughest ones to get through. And if you had more than one criteria, maybe it was starting to add up, but it was not there. And certainly age, aspiration made no difference at all and can be sort of left out of any equation. So conclusion of this, but so the ex-vivo perfusion studies had lots of cases that we just transplant without it. So as a result, it's mostly about the surgeons. You can talking about assessing the lungs, but age, smoking you knew about, DCD you knew about, a nervous surgeon playing with them as it gets longer to play with them. It's the evidence that's actually resuscitating surprisingly small. The next thing was, it'll give you lots more lungs because the surgeons will be now more confident to do them. And again, we looked at 1,000 referrals, which I'll talk about. And there's a recent paper here from just earlier this year with 23,000 lung transplants that said that the 813 ex-vivo perfusions done in the US didn't actually explain the change in numbers and had a 1.6 times worse survival. An odds ratio of 1.6 worse survival than if they didn't go on EVLP. Which was interesting. So we'll hear more about that. If we looked at the potential in 1,000 transplants, of which there was, as I said, 300 and something transplanted, and there was a number that were declined. And because of the fact that you often had multiple factors, they were old with marginal lungs, or they had, there was multiple things going on at the same time. Realistically, there could have been possibly 16 EVLP cases. The general medical issues, there was 4. And if anything, the biggest case was the organisational ones, which is mostly about timing. And that may now be completely out of the picture with the change in the 10-degree fridges, which people are using, which now extend the times and make it easier to move the times. So you might end up with 4% extra transplants done, assuming a 50% conversion using this, because the machine doesn't actually improve things, it may actually make some of them worse. So in conclusion here, that lung quality issues are very common. Smoking history, lung disease, and abnormal chest X-ray, you see those up front. Many of them actually have multiple problems. And of these, these EVLP cases, there was in our centre, there was 15 cases in 5 years, which is actually only 1.5% of all the referrals that you get. So it was not exactly going to make a big difference. And indeed, we've stopped using it with that in mind. The final sort of area of attack here is that ex-vivo perfusion may actually make the DCD lungs in particular worse. The famous paper from the centre that's somewhere else in Canada in 2011 talked of 20 cases. 9 of them were DCD cases, and 2 of those died within 30 days. We now know that DCD does perfectly well without using this machine at all. And in fact, serially they've published on this, and 2015, 2020, and I looked here at our 2021, and if you just read across there, primary graft dysfunction at 72 hours with they said to start with, it's 3% versus our 18% baseline. Then it was 13% versus their 10% baseline, and we get 8%. So we're not getting any big difference there. The survival's essentially the same, and there's nothing to talk of there. Sorry, and we're heading towards 300 transplants of DCD now, with none of them have ever been on EVLP. And most interestingly, down the bottom is again a review of UNOS, which says that they do work, that there's a 9% difference in survival. And of course, the hypothesis is that, you wouldn't have done those transplants without the ex-vivo machine, because and so if you take a little bit of hits because they're not as good. Of course, the alternative hypothesis is that the machine makes no difference or makes them worse. This is the other machine that you can use, the Transmedics machine, and they have an amazing primary graft dysfunction rate in the blue, of the DCD donors, which is 62% of them didn't work just coming out of the operating room. They'd get it down to 8%, 6% at the end and say, that just shows how well how the machine works to improve these very damaged lungs. And again, this is the point that the 62% not working out of the operating room is because the machines muck them up. So the EVLP summary, the studies and the publications describe reassuring the surgeons rather than resuscitating lungs. There are ways in the future that it can resuscitate lungs. There's tricks that can be applied, but currently used just as a way to fondle the lungs is not showing actually as good an outcomes as those without the machine and good management. There's media, there's big dollar bias, and the EVLP conclusions are clear to me. There's a null hypothesis. As currently practiced, it needs an RCT, and the millions and millions of dollars on it are questionable. So in conclusion, there's a lung donor journey that we've been on. We work across a whole continent, use a high proportion of lungs, but there's still lots of other subclasses and categories and bits and pieces that we've used, particularly in the DCD, in hospital and out of hospital arrests, and that we could talk about. Communication and involvement of the physicians and the intensivist together, looking at protocols and what lungs can be got across the line, are important to increasing the numbers. And the surgeons can be left to be rested and not grumpy to do the tough operations during the day. Guidelines, definitions, auditing and benchmarking are required because there's definitely stuff out there that sounds good, but when you actually check it, it doesn't actually fit with what we've seen. And in the last line, Ex-Vivo Perfusion, as used to date, is overrated. Thank you.
Okay, so some controversy. Anybody has any questions, please raise your hand. I'm going to start off. So, it's fairly clear what you think about EVLP as a lung resuscitation strategy. And I think you presented evidence to support that, and have published that evidence. What do you think about kind of the emerging topic about EVLP as a therapeutic strategy for pathogens, for pulmonary emboli, for CMV?
So I think it is a platform that enables you to keep the lung alive while you manipulate some part of the process. And there's any number of studies been done in any number of centres now. There's probably 150 papers out there describing something happening, but some therapy, but it's actually bringing them out. So until they do that, I think at the moment it's just to assess organs. It's not as critical as perhaps stated. And there is a massive industry, particularly in the US, that's forcing people onto the Transmedic system and through some of the ex-vivo centres where they just take them and sort of say they're resuscitating them, checking them, and then they almost re-refer them on to someone else in North America. So I think there's all sorts of ways you can treat the organs, but no one's actually doing that at the minute. And until they do that and show that there's a group that you really wouldn't have used otherwise. You could also do RCTs where you drop the numbers down. You say, okay, instead of an oxygen of 300, let's put an oxygen of 150, or every one of them has to have an X-ray and low oxygen and something else, and put them there and show that you can actually improve those. But there's a reluctance, it seems, to put anything to an actual trial. It's just historical. They're also trying to, and it adds a massive cost. The cost of the consumables is $40,000 to $50,000 per case, and that could be better spent elsewhere at the moment.
Thank you, Greg, and I really appreciated the week we spent together and the really meaningful conversation and the time you spent in our lab and looking at what we do here. And I don't disagree with the comments that you made in the iteration of the technologies that are available to date. I think that's an important differentiating factor with regards to what the current form of EVLPs do to these organs. For example, until Darren Freed created the first negative pressure ventilation EVLP device, these are all by positive pressure ventilation, which we know continues to exacerbate barotrauma that most of these donors have, and may explain why some of those very early PGD rates are even worse. So there's real technological or methodological concerns with regards to mimicry of true physiology, which isn't there yet, but it is clearly an opportunity to build a better mousetrap, if you will, which is what we continue to do in our lab. Because ultimately, the length of safe perfusion is going to define the utility of the technology. So, you know, things that could be done in collaboration with regards to tolerance protocols or all the fancy things we hope to do, ABO, things that Lori does, has to evolve around something that keeps those organs safe. If we're ever going to consider the opportunity of a future biobank of viable organs, because either they're in hibernation or some form of cryo subnormal thermic preservation that can then later be resuscitated, there's going to have to be objective metrics before you determine that those still have transplant suitability. So I do agree with you with the current iteration of technologies that are commercially available, especially with the commercial bias for the cost, there's a lack of efficacy. I think some of these smaller programs probably don't have the experience that your program or our program have at this time with the comfort of that donor assessment. And that leads to probably turn downs that should be acceptances. I would also, you know, say that the 10-degree cooler has changed things. Logistically, we are safe to take things out to 14-ish hours now that in my experience with that. But more importantly, the breadth and scope of the ICUs we work with now here in our cardiovascular ICU and the comfort with veno ECMO, both as a bridge to transplant and then in the perioperative setting, has really allowed for organs to have the ultimate resuscitation in an in vivo environment attached to a liver, attached to a kidney, and all the other things that allow for probably rapid improvement, as was seen in that anti-venom patient. So, you know, those would be my general comments. It hasn't hurt my feelings too much on my fingers, but I appreciate where we need to go to truly make this prime.
No, I absolutely agree, and I think it's just important for people to understand where we're at, and that the magic that's been promoted is you know 62% of the whole experience has been on DCD, which we now know does worse, not even the same. So no wonder they, you know, that it's, you know, you just got to subtract every one of those virtually off the DCD results to work out what it would have actually done. So because those DCD lungs are always going to work.
Just two quick administrative notes. I think Kieran did a side job in marketing. This is an amazing turnout, but there is a sign-in sheet somewhere back there. If you can hear you, you can just pass it along.
We circulated it.
We should. I signed for everybody.
I want to Dr. Singh.
Great talk. Thank you for making the trip to. I appreciate it. Can you enlighten me a little bit about the other center in Canada that does lung transplants and the partnership they have with this bioengineering company in the States where they're resuscitating, bronching these organs? What is that all?
So there's now, I think, 2 centres in the States that are sent organs to resuscitate or assess. Sorry, to resuscitate or assess or resuscitate is probably the better way to put it. And some of those are compulsorily sent on to those groups, and then they sort of package it again and film it, and will then send that out to centres to see who will pick those up. So there's over 1,000 of those being done, and they're saying they're getting the same results as if as a normal transplant, but we would have said that's what would have been happening. So it's becoming more common, both with the ex-vivo equivalent and the transmedics equivalent, which I've shown.
Just follow up. Recently, I saw a bill to a patient to Jack in the States. It wasn't a kidney transplant was saying $150,000 for the kidney per month, 7 days in the 105,000 of that was for agency in the States. 30,000. for 7 days. Agreeable and whatever goes on. And how much of that is the business model in the US with the very profit driven where the donation you put down and sort of putting the scene with clients and is it better off to take that money and value somewhere else?
I think the answer is exactly what you would think. It's better elsewhere. I spoke to Marcello Saipel last week, sorry, 2 weeks ago now, and he was described. I said, "How many of these organs are you getting in Toronto?" And he said that he gets a phone call about organs that have been where the donor has gone to a donor centre and the donor organs are retrieved by the local retrieving team, who put them in the OPO's jet, using the OPO's transport to get there. The jet takes them either with Transmedic's machine, or they go to the centre, which does the in Baltimore, that does the Ex-Vivo. And he's making the point that it's, they actually set up that centre and those organs he wouldn't have put on a machine, but he's asked to pay for the assessment, the team, the jet, and the donor time. And he said it's between 210 and 260,000. I think he was saying US dollars. So he said they're not getting as many organs from the US based on this, because it is a scheme where everyone's adding their bid in, and this is quite a radical change.
This is just on top of the transplant costs.
They still charge. So in that is $60,000 for the organ. And that's just to have the organ arrive in your centre, and you don't actually get any control of those things, and you don't get a chance to feedback and ask the questions and find the subtlety of some of the donor factors that because you're the third hand in the chain of events. So it seems to have got completely out of control.
Leni, I think you had Dr. Papanaki next.
Okay, so.
Okay.
Oh, sorry, go ahead.
Oh, sorry. Just as we often use Australia as an example of programs that routinely do a long ischemic time because of long distances. I wonder what your thoughts are on the effect of ischemic time on functioning. Have you found anything to mitigate the effects of it?
I think that 10 degree refrigeration is going to be the answer to make a big difference to that. I think there's two types of ischemic time, and people get them a bit confused when they analyse it. There's ischemic time where up till now they've been sitting on ice, and the organ is sort of perfectly happy at a low temperature. And I don't think the lungs quite get as frozen as some of the other organs, but then there's a relatively quick operation. And then there's the reverse, where the time is the same, but the organs come out of ice, there's warm ischemic time, the surgeon's got throwing all the toys out of the pram, there's blood everywhere, and that organ's then 8 hours before it's properly reperfused, and there's been major problems. So it appears you need to subtract those, you need to split off those two types of ischemic time to actually understand. And I wonder if some of the I'm sure some of the studies in the past in lungs have failed to recognise that there's two very different types of transplants being done there to explain that. I don't think ischemic time, again, the times that we've extended through problems with transport, we haven't actually noticed anything over the years. So I don't really know what the routine longest ischemic time should be, and the evidence that at 6 hours, 8 hours that we're making any difference at all is I'm a bit sceptical about. 10 degree thing may even be real as well. Yeah, we'll find out.
Leni, go ahead. Yes.
Disclaimer, I'm not a surgeon, I'm not a transplant. One of my first publications. Anyway, my question is a little different. I may go different direction than some interested in transplant. Didn't comment if you're seeing a lot of effects of vaping, which is not the same, and how is the lung transplant, which has very different effects.
We have rules that mean that vaping's not that common. Sorry, is not still nowhere near as common as, maybe it's about the same incidence as smoking these days, I suppose. But we certainly track all of this in the donors. We haven't had the sort of serial 20-year vapors, but we've had a few cases now of acute, like over 6 months or so, where they seem to have just filled in their lungs with some sort of inflammatory milieu that we don't quite understand, and including in a 14-year-old who everything else was tried and were forced to transplant. So I think there may be a bit of there may be troubles to come with vaping.
Yeah, we've transplanted, I think, 2 cases of acute vaping lung injury that, were non-responsive to all other methods for sure.
From a donor perspective, we'd still accept those. Yeah, that hasn't been as common. We've been tracking, because of our interest in this, we've been tracking all the other bits and pieces from ice and cocaine and all sorts of other things, and haven't shown any as much trouble, particularly from ice. Hasn't been as big a problem as marijuana.
Wait, I think you've had your hand up 7 different times.
Great talk, and I just have a question of DC. In one of the slides, you mentioned that the lung can actually survive up to 2 hours after death. Your practice in Alfred, the team will wait for 90 minutes. Is that your practice?
We wait for 2 hours, but we firmly believe that it's all about the blood pressure going along and then falling below 50, 60. And if it falls to 50, 60, it will keep going once you've withdrawn treatment in the ICU. And we've got a program that's looking at what we've called time extended DCDs. And ironically, that's ended up with 2 transplants that occurred when the person did actually have reach asystole in the 2 hours that we had predicted it wouldn't, but we were prepared to go longer. One case where we actually retrieved the lungs at 9.5 hours after withdrawal of treatment, where the blood pressure had stayed right through the night and then nicely fell onto the operating list in the morning. And then there was one further 4th case where the patient didn't arrest in the whole 24 hours afterwards, which was our time. So we're now following that up with a window of 2 hours afterwards, and we'll give some CPAP, I think, just to start the program going. So we re-intubated at 30 hours after death, 30 minutes after death, and just kept at 20 centimetres of water pressure, and theatre will be available within 2 hours, and away we go with that. So that's a couple.
And just for context, for the non-transplant folks in the room, we're talking about donors that have not met brain death criteria, but where care is withdrawn. And then in Canada, we have a very firm 2-hour window where if they progress to arrest during that time frame, we go on to donation. But lots of people in the room have had candidates waiting where we thought we had a donor, and then we don't have a donor because of this process. So everybody's looking for solutions to this as to how we can optimize and increase.
And it's not ischemia, it's the limits. It's having an operating room available for X number of hours. And that's where we created the protocol that meant that we would go just by some time with no ventilation, no anything, but it would give us a couple of hours to have an emergency theatre available to get the donor there. But otherwise, what you don't want is to have the team just standing there twiddling their thumbs, waiting, because that gets people upset, particularly in our situation where 37%, where when treatment's withdrawn, 37% will not progress. It is a bit predictable, but not much better than that. A worrying trend in the US, in New York 2 weeks ago, talking about all of this. 98% of DCD withdrawals in the US, in New York, were progressing through to arrest, and then hearts and lungs being retrieved using NRP, and that is a bit of a worrying trend because, as I've mentioned to the team, that's the same statistics that occur in the Netherlands and Belgium, and is referred to as euthanasia there.
Dr. Ferraro. And then
Thank you again for this wonderful talk, and the discussion is really great. I'm not in the field, so I might say something very stupid now. But I was really impressed by your smoking history analysis on the survival of the recipients. And I wonder if you consider all the back here or also structural changes in the lab. And also, because a few years ago, I had an interaction from some colleagues from Gothenburg. And what we were using was to use the EVLP test value with the lungs in the presence of moderate empathy amount, lungs that we will have discharge.
So we look at the pack year total and current and sort of current status added together. They're sort of worse added together with emphysematous bleb. Sometimes you can't tell what's barotrauma. Then they may be reasons that we're pulling back at 20 pack years, but it's one of the most critical things is what's the patient's story, if the donor's story. If the donor was going up and downstairs carrying shopping and out and about, then compared to someone who's in a bed in front of you in all sorts of troubles, then it may be still the best thing to go and proceed. So each case is that individual assessment.
Why do the DCD lung do worse after EVLP?
I think it's possible all lungs do. Sorry, there's some evidence that's not presented there from Japanese studies that literally just putting it on the rig, handling it, some of the pressure changes. It's very easy in a closed left atrial circuit to just end up with the lungs actually getting a little wet and possibly causing vascular changes that pay you back with primary graft dysfunction. And so, for example, the Transmedics one, which had 62% of the lungs not being right to start with, it strongly suggested that they were doing something, that the Transmedic system with the settings was actually contributing to more troubles with those lungs than not.
But mechanistically, it's not understood. Is it vascular damage or?
No.
This is a wonderful talk, and it brings out all kinds of science, but one of the underlying theme here is tissue injury and being able to read the tissue and understand, and actually from there to develop interventions, the interventions which could improve overall wound healing, understand the messages and develop interventions, because that's how breast cancer or inflammatory bowel disease have progressed. We've learned to read the messages in the tissue and tell things that we can intervene and make things better. And from that point of view, what do you think that it is worthwhile just studying the tissue at the time of transplantation and learning the messages about how the tissue predicts its future behavior? And then from that going to potential interventions against targets that you see could be key factors in the cybernetics of the wound repair.
I think it is important to try and understand what are the short-term and the long-term ones. There's farmer interest in and machine interest in looking at the early signals of primary graft dysfunction. We talked about a complement inhibitor study as well, but it's based on assessments of based on assessments of lavage and blood work. So people are interested in those studies, but in reality, like for the smoking story, can we predict those who are going to get troubles later? I think that would be great to do, and there's no current known mechanism to do that.
Just as a follow-up, does the DCD lung do better than, for example, the DCD kidney or the DCD heart? Because there's actually oxygen available for a period of time.
Yeah, correct. Yeah. So the DCD lung is at the time of after asystole. The lung has 21% oxygen from room air just sitting inside it, and it doesn't pump, it doesn't consume much, so it actually travels quite nicely. And all of the control experiments you need to do to study DCD, you've got to go for like 3 and 4 hours to produce an injury, which people seem to forget about. And then there's a difference between the pigs and we were using greyhounds. And we had to go 6 hours because the greyhound was a bit like a Porsche that would drive pretty well even if it was injured, whereas the pigs that have been kept in a cage and never moved and whatever else, they're a harder model to use and might be more likely to crash early.
I will say too, one of the things about EVLP is it's been a wonderful experimental platform for that question of looking at tissue changes during different ischemic challenges during reperfusion. And that's a big way that, then again, in Free Lab have leveraged it. That's a big way that Toronto have leveraged it. So, we're talking about EVLP in the clinical world, but EVLP in the experimental world is a totally different thing. And it's been a really amazing physiology platform. And molecular platform and therapeutic platform.
Absolutely agree. The other thing about the DCDs, I think, is that I think it's an impression that DCD is a little bit like turning off a computer and it basically sets itself back in a drop in blood pressure that's sort of planned. The body almost sort of goes through the right steps. Whereas if you're brain dead, the whole thing, it's like pulling the plug out of the computer. It may or may not reboot up well. Yeah. So I think that it also explains some of the and there's a belief that there may be a reconditioning effect that you've created with that, or there may be some benefit of considering reconditioning.
Thanks very much. Felt better sitting here thinking about pieces we have planted over the years, but very overlooking young people. I told you about that young CFP million, one son at the time, a 78-year-old girl, not one of his girlfriends. So I think this is to see objectively rather than just guessing when 20 years ago we were guessing at this stuff. But I was interested also in your very low primary graft dysfunction rate at the Alfred. What do you think goes into? I know your experience and I know you have a great team, but there's got to be something to that other than what needs to be on the. Are you coming out more liberally on ECMO, PGD, et cetera? How do you drive over rates?
So a lot of people will quote their severe PGD rates at sort of 15 to 20%, and theirs was 8%.
So I think the unrecognised heroes, I think, in lung transplant are the anaesthesiologists who basically have hours to package the case for the.
There's some online, and they're going to be cheering.
Because I think again. And we've talked about this, that this is still a business to run at the highest level. You bring in people who are doing it, as the work experience kid, and it's very hard to know these nuances. And I think when the anaesthetic goes well, no one sort of says it's very exciting. But when it goes badly, that having the A team is very useful. And I think we have a very skilled anaesthetic team who package this well for the ICU, and then the ICU team. Historically has been tremendous and knowledgeable and as here runs 24 hours a day with senior teams and senior ability to add an ECMO and the like. I think we've diluted that slightly in the last 2 years as they seem to be training too many people to go and work elsewhere. So I think having the most senior staff is the answer to that.
I should say our PGD3 rates were 20% as of 10 years ago and have now come down to sort of 12%, 11%. So they are improving as well, probably through the same processes. Okay. Well, excellent discussion. We've gone right to 1 p.m. So just a few final, I know I get in trouble from Sean if I don't do the housekeeping stuff, but we have 3 final seminars coming up on June 4th, a hybrid seminar with Dr. James Land from UBC, talking about use of donor-derived cell-free DNA. That will be in person in ECA. And then we have June 18th, a rescheduled update from our friends at Give Life Alberta, moderated by Bernie Boulay, the very famous father of Logan Boulay. And then on June 25th, our final seminar of the academic year will be a special seminar with Shahid Marani, Dr. Shahid Marani from University of Nebraska, doing a virtual seminar on normothermic regional perfusion. So yeah, if everybody could just join me. First of all, thank you everybody so much for showing up and for supporting Dr. Snell and joining me in thanking him for traveling all the way to see us and for the great talk.